So we're going to go over the OASIS C2 changes that are happening as of January 1st. This is a continuation or a build on from the last PowerPoint. So the most important thing, until January anyway, is that the OASIS that you complete, you do not change the MU90 date, the date assessment completed, the last week of December. And the reason being is that through here, you can change your MU90 date for like a start of care through the 5th day of your assessment, but you don't want to cross over into January, because if you do an OASIS C1 the last week of December and then you change it to a January MU90 date assessment completed, then you'll need to complete a OASIS C2. So in other words, you're going to be redoing your OASIS. And nobody wants to do that. So any OASIS, any type, started the last week in December, you do not change your MU90 date to cross into January. So just leave your date as is. At the last meeting, we discussed that there were going to be these major formatting changes where you were going to have to enter a number rather than checking a button or a box like we have been doing. And then I learned that CMS does not require the electronic record to display in this format, so the OASIS is not going to change in appearance to what it is that you're used to. So same radio buttons, the same check boxes that you're used to. So none of this stuff you'll need to worry about. What is new is that there is the dash option in some of the questions. So if you could not gather the information, you can enter a dash. And it's not a dash, for us anyway. It's either a checkbox or it's a radio button, and it'll say something to the effect of no information is available. Depending on the question, it kind of varies what the dash response is. 128. These are active diagnoses, comorbidities, and coexisting conditions. And so what CMS wants to know is whether your patient has PVD, PAD, or diabetes. Either yes, no, or no information available. The no information available shouldn't be used that often because we pretty much know what diagnoses the patient has upon start of care. If you aren't sure if the codes that the patient has applies, you can check this box or this box, and this is what shows up. It'll give you all of the ICD-10 codes. Haven't made any other changes to the face sheet. Not sure that we need to. We'll have to kind of see how that goes and see what it is that you guys need to help you answer this question better. The guidance says that if we learn of a new diagnosis or those diagnoses, PVD or PAD or diabetes, after the MU90 date, the assessment time frame of that OASIS, then you cannot change that question. It has to be what was known during the assessment time frame. So height and weight. This was a bit of an issue at the last discussion, and it still is an issue, and it's an issue for every home health agency across the nation. There's been lots of chatter about how it is that we're supposed to use this information or gather this information because the guidance that we've been given is ridiculous. So height and weight is in the vital sign information or the vital sign section. So you're supposed to measure the height in inches and then measure the weight in pounds, and it'll automatically calculate the BMI. If you cannot gather the height or the weight, then you mark the no information available. This is your dash right here. And these fun facts down here. So we cannot use data collected at the hospital or the SNF. So we cannot use what our skilled clinicians did gathered at those other levels of care. We cannot use the patient's self-report of height and weight. So even though most people know how tall they are, we cannot use that information. You have to actually measure them at the start of care or the resumption of care of their height and weight. And if they're a bilateral amputee, you measure their current height. And they said, i.e., after their amputation. So what we've been discussing about how we're going to manage this is we're going to get paper tapes, not these nice ones, but disposable paper tapes, and everyone's going to need to carry them, because if you are a discipline type that can complete a start of care or a resumption of care, you'll need this information, or you'll need to be able to gather it. So the patient's going to need to stand against the wall, shoes off, and then you measure how tall they are. If they cannot stand, then you can use the paper tape and just run it along their body like how they measure babies and gather the information that way. If you cannot get it, it's just not possible, then just mark dash, no information available. With the weight, if they have a scale, use their scale. If they do not have a scale, then we're going to have scales that you can carry in your car. I've asked Jeff that we get bariatric scales because that's going to be necessary. If the patient cannot stand on the scale, if they can't stand on the scale safely, if there's some issue, then mark dash. And just remember that if you do take in the scale that you carry around, that you thoroughly sanitize it between patients. The issue with this question, one of the issues, is it's used to garner case mix points if the patient BMI is at a certain level, and is also used at the discharge to calculate the outcome measure of pressure ulcers. So I haven't seen how that's going to be affected yet, but it's important, but I don't want everybody to get completely hung up and stopped at the appointment and spend a ton of time trying to gather this information. This question was asked of CMS on this question. So can we gather the height and weight by patient caregiver report? M1060A requests most recent height measured since sock rock, but M1060B allows the most recent weight measurement in the last 30 days. So does that mean the height must be actually measured after the start of care, but the weight can be entered based on hospital discharge paperwork documented within the last 30 days? Can we ask the patient or caregiver the patient's height and weight? And CMS says no. The clinician is expected to weigh and measure the patient as part of the comprehensive assessment. And it cannot be by self-report, and it cannot be from caregiver report. And it says to just enter the dash if you are unable to gather that information. And pertaining to the weight look-back period of 30 days, this is at resumption of care only. So you can look back 30 days if the start of care is within that time frame, then you can use that information. But the 30-day look back does not count at start of care because you are supposed to be measuring it at that appointment. Our regulatory board for our national association that lobbies Congress and all of that for our benefit. I'm not going to read this whole thing through, but pretty much it's the regulatory committee sent this to CMS and is saying that the height and weight, not being able to use the information from a SNF or a hospital stay that the patient just had, doesn't seem appropriate, and especially because the hospitals and the SNFs have the specialized weight or the specialized scales to get weight for patients that cannot stand, like bed scales, and then the bariatric scales, and the wheelchairs and all of that. They have that capability, and we don't have that capability in home care. So It would actually be more precise to be able to use what our fellow skilled clinicians gathered in the inpatient facility and just use that information. So we're hoping that CMS is going to reconsider this ridiculous guidance and allow us to utilize the information gathered at the levels of care that are more appropriate to gather this information for some of our patient population. M1306, the unhealed pressure ulcer at stage 2 or higher. The question has not changed, so it's the same question. Does this patient have at least one unhealed pressure ulcer at stage 2 or higher, or designated as unstageable? And this excludes its stage 1 ulcers. What's new is the guidance of the stage 3 and 4 pressure ulcers. So now they're saying once the ulcer has fully granulated and skin has covered it, it's completely closed. That means that it's healed. That's different than what we're doing right now. We're saying that stage 3 and 4 ulcers are counted forever and ever, amen, no matter what they are, whether they're open, they're closed, or whether they were from 12 years ago. But that's changed now. So OASIS C2, starting in January, you do not count stage 3 and 4 pressure ulcers once they are completely epithelialized and they're closed. Now they're gone. I know. So, more guidance. Healed versus unhealed ulcers refer to whether the ulcer is closed versus open. Stage 1 pressure ulcers and suspected deep tissue injury are not counted in this question. You can enter yes when the pressure ulcers are known but to be present but cannot be observed due to a dressing or device, but you of course have to document that. If it's suspected and you don't have documentation, then you don't count it. And a previously closed stage 3 or 4 that is currently open again should be reported at its worst stage. That is guidance that has not changed. And then down here they snuck in a new one, new guidance. A pressure ulcer treated with a skin graft should not be reported as a pressure ulcer, and until the graft edges completely heal, it should be reported as a surgical wound on M1340. That's new because currently in OASIS C1, a pressure ulcer treated with a skin graft is not counted as a surgical wound. So we will be auditing these questions just like we always do. So do the best you can, check the guidance, and if what you've marked is not correct as of C2, then we will help you correct that. Item number change, M1308 to M1311. So now it's M1311 in OASIS C2, and it's the current number of unhealed pressure ulcers at each stage. So if you said yes to the previous question of whether there's a pressure ulcer at a stage 2 or higher, then 1311 will pop up, and it just needs to know whether, you know, how many stage 2s, stage 3s, stage 4s, on and on. Just like you are answering right now, it's just a different numbered question. And this is done at start of care, resumption of care, recert and other follow-up, and discharge. Then at follow-up and discharge, the same question, M1311, current number of unhealed pressure ulcers at each stage. But at these time points, follow-up and discharge, you answer how many stage 3s are currently there, and then how many of those stage 3s were noted at the time of the most recent start of care or resumption of care. So at follow-up and discharge, you'll be answering each stage with two answers. What it was, or what it is now, and then if what's there now was present at the most recent start of care, resumption of care, or how many of them. Again, we will help you with that, but I think it's pretty obvious what they're asking. And this question is kind of a rehash from a previous question that caused a lot of issues about how to determine how many ulcers are present at each stage and what was present at the most recent start of care, resumption of care. So hopefully this is going to be a little bit easier. So M2000 is now M2001, drug regimen review. What did change are the examples of what a drug regimen review consists of is taken out of the question. So it's just, did a complete drug regimen review identify potential clinically significant medication issues? And remember that a drug regimen review is required of every single patient in home health, regardless of payer source. Not assessed or not reviewed is no longer an option because it is required of every single patient, regardless of payer source and regardless of clinician type that's doing the assessment. Slight changes to the wording in response options, problems to issues, and response NA is now 9 response NA. So you have no issues found, 1, yes, issues found, 9, NA, patient is not taking any meds, and then no information available or not able to determine is the dash. The guidance for M2001, because they took this information out of the question, is just kind of a reminder that the drug regimen review includes all meds that are prescribed over the counter, herbals, and administered by any route. So it doesn't matter what route, it's included in the regimen review. And a potential existing clinically significant medication issue is an issue that in the clinician's judgment requires physician notification by midnight of the next calendar day at the latest. So this is the same thing where you have to contact the physician by the next day and they have to get back with you, but they just further defined it's by midnight of the next calendar day. Potential or actual clinically significant med issues may include, but are not limited to, adverse reactions, ineffective drug therapy, side effects, drug interactions, duplicate therapy, omissions, dosage errors, and non-adherence. So to be able to answer 0, no issues found on the drug regimen review, these need to be true. So the list of medications from the inpatient facility matches with the medications that the patient gives to you at the start of care, saying that this is what I take. The assessment shows that the diagnoses, symptoms for which the patient is taking the meds are adequately controlled as able to be assessed within the clinician's scope of practice. So take a breath, PTs and OTs, take a breath. The patient possesses all the meds prescribed. And the patient has a plan for taking the meds safely at the right time. And the patient is not showing signs and symptoms that could be adverse reactions caused by medications. Again, as able to be assessed within your scope of practice. So examples of some potential clinically significant med issues are the discharge instructions do not match what the patient gives you. The assessment shows that the diagnoses, symptoms for which the patient is taking the meds are not adequately controlled. Patient seems confused about when or how to take the meds, indicating a high risk for errors. Patient has not obtained medications or indicates that he or she will probably not take the prescribed meds because of financial, access, cultural, or other issues. Or patient has signs and symptoms that could be adverse reactions. Patient takes multiple non-prescribed meds, over-the-counters, herbals, supplements that could interact with prescribed medications. Or medications are prescribed by multiple physicians and or obtained from multiple pharmacies, so the risk of drug interactions is high. And they highlight now in the guidance that any of these circumstances must reach a level of clinical significance that warrants notification of the physician for a change in orders or recommendations by midnight of the next calendar day at the latest. Any circumstance that does not require this immediate attention is not considered a potential or actual clinically significant medication issue. So you would not send that information to the physician via fax after you do your validation unless it meets this level of clinical significance, or a phone call to them. So if you are unsure about whether or not a certain interaction that you have during medication validation is one that fits this definition of a potential clinically significant med issue, you can just ask one of us, one of the nurses, me, Alana, Jeannie, or a fellow nurse on your team or that you work with. Do you think that this is an issue that needs to be reported? Is this a potential clinically significant med issue? If it's just a patient guidance or education issue, that doesn't need to be sent to the physician. That just needs to be communicated to the patient. So item change M2002 to M2003, and it's the medication follow-up question. So did the agency contact a physician by midnight of the next calendar day and complete the prescribed recommended actions in response to the identified potential clinically significant med issues? And they highlight that it must be within 1 calendar day, clarified as by midnight of the next calendar day. All issues are labeled potential clinically significant med issues for consistency, and contact physician or designee and complete the interventions required by midnight of the next calendar day. So you can't say that you contacted the physician unless they have communicated back with us, not the ALF, but us, how to resolve the potential clinically significant issue. So they have to get back with us. They have to fax back, call back, somehow get back with us. If they do not within the time frame of midnight of the next calendar day, then you cannot say yes that the physician was contacted, even though they were. M2004 is now M2005. And did the agency contact and complete the physician prescribed recommended actions by midnight of the next calendar day each time to resolve the issues? You are answering this question at transfer, death, and discharge from agency, not to an inpatient facility. And just clarifying, it's wanting to know, did we contact the physician and did they get back with us with some type of recommendation on how to manage that potential interaction each time potential clinically significant med issues were identified? So the each time, that's different. You know, the 9 NA, there were no potential clinically significant med issues identified since the last, or since start of care, resumption of care, or the patient's not taking any meds. And then, of course, the dash, no information available. This should not be used often, and it cannot be used as just a quick way to get past this question, although that'd probably be nice. But we're going to have to do some kind of chart review or some, I don't know, I need you guys to start thinking bigger about how we're going to communicate these things, because the clinicians that are doing the transfer, death, and discharge from agency may not be the ones that identified the issues and communicated to the physician. And, you know, did the physician get back with us? I mean, you can't look at every single note. So I do not have an answer at this time how to communicate this within our software system, but we need to come up with something. So throw me your ideas. We're open because I don't have any. So I'm sorry, but besides going into each note, which is not possible to do, and looking to see if there was a med issue identified and did the doctor get back with us to resolve it, this is going to be a challenge to answer. And I recognize that, and I apologize for that, but I didn't make the question. But I do not have an answer about how we're going to manage it yet. So I'm open. This is just an FYI. There's a new section. It's called Total Medication Count. And a couple of clinicians I've noticed are filling this information out, and some people have contacted me asking how are we supposed to do this, and this is not a required section. This is for agencies that do medication counts. So whether it be narcotics or whether you're counting, the antibiotics to make sure that the patient is actually taking them as prescribed. This is not a required section. You do not have to fill anything out here. We do not have an agency policy that's stating that you do need to count meds. If you consider that something that you feel you need to do to make sure that the patient is taking the meds as prescribed and you want to use this, you can, but it's not required. So I just wanted to make that mention. The medication validation and observations are no longer hidden. So currently in OASIS C1, the question is, have the patient's meds changed since the last visit or as a result of a hospitalization? We've had to say yes, so that the medication review expands out. So obviously Cerner recognized how stupid that was, and so now the validation is not hidden. It's underneath the question in the medication section. So you would just mark your validation date and time box, and then your validation will populate. You also have the option of adding in observations or reports. Here is our newest item to OASIS. This is part of the Impact Act of 2014, where CMS is attempting to have all of the assessment tools from all levels of post-acute care be the same, so that you can compare patient progress, apples to apples, as it were, from the very beginning. And so for home health, we are just starting with this one question incorporated into the OASIS of GG 0170C mobility, and it's bed mobility is all that it's assessing at this time. So there's quite a few differences between this question and the OASIS questions, so please pay close attention to the guidance. So this is just assessing their ability of lying to sitting on the side of the bed, to move from lying with their back sitting on the side of the bed, with feet flat on the floor, and with no back support. You're using a 1 through 6 scale like many of the OASIS questions, except that 6 is the first option rather than 1. And 6 is the most independent level, and it goes down to the most dependent level, which is opposite from all the other OASIS questions. There is a dash available for the option of no information is available or unable to complete the assessment for other reason. If you are not able, or the patient is not able to complete this this mobility, then you have these options down here: patient refused, not applicable, or not attempted due to medical condition or safety concerns. So if you can't, assess or determine using the 1 through 6, then you come down here and do 7, 9, and then 88 before you ever consider using the dash. There is a discharge goal that is required to be answered at the start of care or resumption of care on GG 0170C. So you assess what their safe ability is to do the bed mobility in the first place, and then you are assessing or determining what you would think that they will be able to do by discharge. And so it's the same 6-point scale going from 6 independent as the first one down to 1, the most dependent at the bottom, and then you also have the dash. This doesn't have the 7, 9, and 88, that they didn't perform it, because this is what you are projecting they hopefully will be able to do by discharge. So do your best determination based on what you see at the start of care, resumption of care, and then based on your plan of care and your visit orders and the other people that are involved, the other team members, indicate what your discharge goal would be for that patient for bed mobility. Guidance from CMS, because your peers have asked the question. We have patients that sleep in a recliner and not in a bed. We currently have a patient who sleeps on a mattress on the floor. GG0170C is about bed mobility and describes a patient who sleeps in a bed and requires sitting at the side of the bed with feet flat on the floor. How do we assess this item for our patients who do not sleep in a bed, or patients who are unable to reach the floor sitting at the side of the bedside due to bed height or leg length? And CMS says if the patient uses a recliner, sofa, or mattress on the floor as the patient's preferred or necessary sleeping surface, assess the need for assistance using that sleeping surface. And if their feet do not reach the floor and the patient performs the activity of getting from lying to sitting independently and safely, the patient can be scored as 6 independent. If the clinician feels the patient is not safe sitting at the bedside without their feet on the floor and requires assist to lower the bed prior to the transfer or to place a footstool prior to the transfer, the patient can be scored as 5 setup or cleanup assistance. And report the help that the patient needs to complete the lying to sitting transfer, understanding that in some cases your clinical judgment will be required. So that is all I have. Thank you very much for your time. If you have any questions, please don't hesitate to ask. We're here to help, and I appreciate your time, and I hope you have a wonderful day.